Thank you, sir. Am I audible, sir?
Yes.
Yes.
Audible.
Okay, sir.
Audible, and your slide is visible also.
Thank you, sir.
Please start.
So,
Bolo.
in the fag end of this lecture series and the academic feast, I will be dealing with the preoperative cardiovascular evaluation for non-cardiac surgery, which we are frequently called by our surgical colleagues. Now, why do we have to undertake this task of a this evaluation procedures? So the thing is that this is done to identify the increased risk and to provide the surgeons and the patients the benefit to risk ratio for the procedures, that is whether actually that it is justified to take the risk. The patient should take this risk to undergo the procedures in presence of his previous comorbidities. So why is this required? That is required is because there is a small but significant chance of perioperative MI, and it is to the tune of 1.4%, and a cardiac death to the tune of 1% among unselected surgical patients. And various other studies have found, with some selection criteria, the rise in the perioperative MI may be increased to the tune of 3.2%, and cardiac death to 1.7%, and that is quite significant. And therefore, we actually help the patient, help our surgical colleagues to choose their patients who they plan to, who they actually post for surgical procedures. And for that reason, we also have to look for if the patient has some adverse cardiological outcomes related to the baseline risk. So before after we have been called for assessment of the risk factors, we have to take a good clinical history, and that includes whether the common cardinal symptoms of the patients who has cardiac disease. That includes whether the patient has a history of dyspnea or orthopnea or PND, whether the patient gives a history of palpitations or syncope, or there is history of any angina. A good clinical examination will also help us in assessing the risk, and that includes looking for the raised JVP, bibasal rails, S3 gallop, or pedal edema. Coming to the various risk factors, the one major thing that we can encounter is the valvular heart disease, and in that case, we have to ask these patients to go for an echocardiographic study if there is no prior echocardiography, or whether if there is a change in the clinical scenario of the patient in the following the last evaluation. And for patients who have a standard indications for interventions, that is either replacement or repair of the particular valve, and these patients should undergo the procedures before their patient is posted for an elective non-cardiac surgery. We all note this thing, that patients with stenotic lesions like aortic stenosis or mitral stenosis, they have an elevated cardiac risk, and these patients actually should undergo strict hemodynamic perioperative monitoring. For example, the mitral stenosis patients, these patients should be maintained in a euvolemic state. They should not, the heart rate should not increase, the blood pressure should be maintained in a narrow range, and these patients should not be volume loaded. The other conditions are the regurgitant lesions, and these patients with severe regurgitant lesions like MR or AR, these patients should also has an elevated risk and requires special monitoring, hemodynamic monitoring during the surgical procedures. I will discuss with the implantable devices in the later part. The other risk factors include the chronic pulmonary vascular therapy, and these patients should continue with the phosphodiesterase type 5 inhibitors or soluble guanylate cyclase inhibitors or endothelin receptor antagonists and other drugs, and unless they are contraindicated or not tolerated. And if possible, these patients should be evaluated by a specialist who deal with the pulmonary hypertension before being posted for a surgery. The other things that other clinical or diseases that actually increases the risk include heart failures, and that includes the preserved as well as the reduced ejection fractions. So we all know that patients who have a reduced ejection fraction will actually have a more or a higher risk. But even then, patients who have a preserved ejection fraction are also at increased risk of perioperative mortality and morbidity in comparison to those who don't have this disease. So coming to a stepwise approach as advocated by the European Society of Cardiology, and first we have to look whether the surgery is urgent or not. So how do we define an urgent surgery? Is that emergency procedure is that life or limb will be threatened if the surgical procedure is not done within 6 hours. And urgent is that the surgery should be done typically between 6 to 24 hours. An elective procedure is one in which the procedure can be delayed up to a year. So the next thing is we have to see whether the patient is having any active or unstable cardiac conditions that include any arrhythmias or heart failures, etc. And what is the risk of the surgical procedures? What is the functional capacity of the patient? And in patients with poor functional capacity, we have to consider the risk for the surgical procedure again and revisit whether the decision of putting the patient under knife. The sixth step is consider the cardiac risk factors, and the seventh is consider non-invasive testing in patients who we have whom we plan to proceed to go for surgery. So first, step one, whether surgery is urgent or not. If it is urgent, then we have to look for the patient and the surgical specific risk factors that dictate the strategy, and do not allow further cardiac testing. And then we have to look at the various pros and cons, the surveillance during the procedures, and continuation of the management, and we go on for the surgery. Step two is that if the patient is having any active or unstable cardiac conditions, like any unstable angina pectoris, acute heart failure, there is significant cardiac arrhythmias, or symptomatic valvular heart disease, or recent MI or residual myocardial ischemia. So in this case, we have to postpone the procedures, or the treatment options should be discussed. If we cannot postpone, the treatment procedures should be discussed in a multidisciplinary team and involving all the operative care physicians, and then we can go for surgery. If the answer is no, then we assess the risk factors. So there are various procedures. There is superficial surgery have a low risk. There are certain surgeries which have intermediate risk of 1 to 5%, and a high risk surgery having a risk of more than 5%. So calculation of the risk to predict perioperative cardiac morbidity, there are various risks like the risk factors, and that calculate that predict the perioperative MACE and undergoing the non-cardiac surgical procedures like RCRI, etc., etc. So the other way that we can do is this Duke Activity Status Index, and these are the following questionnaires that actually help in assessment of the functional capacity of the patient. So the functional capacity can be classified as excellent if it is more than 10 minutes, good, that is 7 to 10 minutes, moderate 4 to 6 minutes, and poor if less than 4 minutes. And based on the MACE trial, if the score is more than 34, there is actually 7 minutes is appropriate, and it denotes a very low risk for the surgery of this patient. Even a risk between 4 to 7 also can be put under knife, and these may also carry a less risk. However, score less than 4 actually indicates a very high risk, not a very high, a high risk for surgery in that particular patient. So this is the stepwise approach that I have taken from the ACC/AHA guideline that is published in 2014, and that was the latest. And so The patient who is scheduled for the surgery with known or risk factors for CAD, in that patient, we have to first step is we know whether the surgery is emergency or not. If emergency, we proceed for the risk stratification and then go for the surgery. If no, then we evaluate. We ask whether the patient has a history of ACS or not. If the patient has a ACS history, then we have to evaluate and treat the patient according to the guideline-directed medical therapy. If no, and then we have to estimate the perioperative risk of MACE based on the combined clinical and surgical risk. If the patient has a low risk, then no further testing is necessary and we can proceed for the surgery. If there is an elevated risk, and if then we have to assess the functional capacity of the patient. If it is more than 4 minutes, then we can go for surgery. If it is no, or if it is unknown, in that case, we have to take decision whether further testing will impact the decision making of the perioperative care. If an answer is yes, then we can go for a pharmacological stress testing. In that case, we can go either for a myocardial perfusion imaging in these patients, or maybe we can go for a dobutamine stress. One thing that we have to know, that patients who have a MPI and in which there is a fixed effect, in that case, the long-term outcome will be the long-term perioperative mortality will be higher. Long-term mortality, whereas the patients who has a perfusion defect with stress, these patients have a higher perioperative mortality. So if the pharmacological stress is abnormal, and there is a perfusion defect is there on stress testing, then we have to go for a coronary revascularization as per the existing clinical practical guidelines. And after that only we can proceed for the surgery, or maybe we can put the patient on medical therapy, or may try alternative therapies in those patients. So I have already discussed the clinical risk factors, and there is another step. This has been incorporated by the ESC, and if the number of risk factors is less than 2, in that case, if the resting echocardiography and the biomarkers for evaluation may be done, and in this case we can proceed for the surgery. And whereas if the number of risk factors is more than 3, then we can go for cardiac stress testing. If there is extensive ischemia, then in that case we can go for the revascularization in those patients before going for surgery. Or if there is a no or moderate stress-induced ischemia, then we can proceed for the surgery in those group. For extensive ischemia, there are 4 options according to the ESC. One is the balloon angioplasty, and following the balloon angioplasty, the surgery can be performed around 2 weeks, more than 2 weeks after the intervention, with continuation of aspirin treatment. If the patient has been put on a bare metal stent, or if we plan for a bare metal stent, the surgery can be performed after 4 weeks after intervention, and dual antiplatelet should be continued for at least 4 weeks. Surgery can be for if the patient is put on DES, then we have to defer the surgery till 12 months. However, it can be done after 6 months with newer generation of DES, with the caveat that there is increased chance of stent thrombosis if we plan to stop the antiplatelet. And other option is the CABG. So actually these steps, where balloon angioplasty and these other procedures are actually planned based on the urgency of the surgical procedure that need to be performed. After that, we'll discuss regarding the supplemental preoperative evaluation. So ECGs. So for ECG, 12-lead ECG is reasonable for patients who have coronary heart disease or significant arrhythmias, and those with significant structural heart disease, who actually, except for those who have a except for those who have undergo low-risk procedures. The preoperative resting 12-lead ECG may be also be considered in patients without known coronary heart disease, who actually undergo moderate or high risk cardiac surgeries. Assessment of LV function is reasonable in patients who have dyspnea or unknown origin of dyspnea of unknown origin, or the patients who have a heart failure, history of heart failure with worsening dyspnea, or any change in the clinical scenario. Also, it may be done for reassessment of LV function in clinically stable patients who has a previously documented LV dysfunction. So, again to remind that patients who have a systolic dysfunction have a higher risk for.
Sir, please conclude.
Oh, sorry,
The
sir.
time is over.
Okay, sir. The other test that can be the patients can undergo is the exercise-induced stress testing in selected cases, and cardiopulmonary stress testing for patients who have elevated risk procedures may be performed. And non-invasive stress testing may also be performed with patients who has a poor functional capacity. But routine preoperative coronary angioplasty is not recommended for coronary intervention. That is, coronary angiography is not recommended for patients. Due to lack of time, I will not be discussing the perioperative therapy, except that patients who are put on beta blockers, who are already on beta blockers, may continue the drug therapy during the perioperative period without stopping. So, thank you all. So, perioperative risk assessment decisions should be informed by focused history, physical examination, and assessment of functional limitation and comprehensive organized